Welcome to LIMBWatch, the global movement dedicated to protecting limbs, preventing amputations, and transforming the future of diabetic foot care. Today, we are honored to welcome one of the world's most influential voices in diabetes and diabetic foot care, Dr. Andrew Boulton. Dr. Andrew Boulton has dedicated his career to improving the understanding and management of diabetic complications, particularly diabetic neuropathy, and the prevention of foot complications. His research, leadership, and advocacy has shaped how healthcare professionals around the world approach diabetic foot disease. Dr. Andrew Boulton is a graduate of Newcastle upon Tyne and subsequently trained in Sheffield and Miami prior to accepting an appointment at Manchester University. He has authored more than 600 peer-reviewed manuscripts, age index greater than 130, and books and chapters mainly focus on diabetic lower limb and renal complications. Among his many awards, he received the American Diabetes Association Roger Bacoro Lectureship Award, the European Association for the Study of Diabetes Camillo Golgi Prize, and was the first recipient of the International Award on Diabetic Foot Research. He also was the 2008 winner of the American Diabetes Association Howard Rifkin Award for Distinguished International Service in Diabetes. He received the 2012 Georgetown Distinguished Achievement Award in Diabetic Limb Salvage. In 2015, he visited Nagoya, Japan, and was given a prize lecture on diabetic foot complications at the Japanese Society of Diabetes. And in 2017, was the Banting Memorial Lecturer at Diabetes UK, and also received the International Diabetes Endocrinologist Award of the Year from the American Association of Clinical Endocrinologists. He also was the previous editor of the Diabetic Medicine, and until recently was the senior associate editor of Diabetes Care. In 2019, he also was ranked the #1 UK diabetes researcher in the field of complications, and September 2025 to be presented the Lifetime Achievement Award at the Diab that happened in Bucharest, Romania. He also was the president of the Worldwide Initiative for Diabetes Education. He served as the president in 2025 to 2020 and served in 2023 to 2025. He also was the founding chairman of the Diabetic Foot Study Group and was previously the chairman of the Postgraduate Education and the honorary secretary and program chair of the European Association for the Study of Diabetes. Until late 2015, he also was the president of the European Association for the Study of Diabetes. And until December 2022, the president of the International Diabetes Federation from 2019 to 2022, and the chairman of the European Alliance for Diabetes Research from 2017 to 2025, and the elected honorary president of the International Diabetes Federation 2025. So welcome, Dr. Andrew Boulton.
Thank you.
Thank you, Dr. Boulton. So, Dr. Boulton, you have dedicated your career to preventing diabetic foot complications. What first made you realize this was an area where you could make the biggest difference?
I think everything comes in my career was by accident. I trained in Newcastle, as you pointed out, and it was well known for neurology. I became very interested in neurology and was planning to do that. And I went to Sheffield and worked with a diabetologist, Professor John Ward, who was really a leading person in diabetic neuropathy. So neurology and diabetes crossed together in neuropathy, and then a chance for a research position with him looking at diabetic foot disease came up. And I was horrified to see how many amputations were occurring, even in the best centers. And I thought we could probably do better. There you go.
Oh, wow. So, Dr. Boulton, when you look back over your career, what accomplishment gives you the greatest sense of pride?
I hope by raising the importance of diabetic foot disease, not only in the UK and the USA where I've worked, but also across the world in my various positions. And I think it was really, a few sentences in the textbook of diabetes, something about the diabetic foot. And we had to do better because it was one of the most important complications that had a huge mortality rate. And so I really felt that we needed to do better. And that's why I started research in the area and tried to improve understanding of what we can do to prevent it by screening, but also looking at evidence-based treatment. So I hope I've raised the awareness across the world of the importance of diabetic foot disease, perhaps most importantly, how it can be easily prevented by early screening. It can be silent until it's too late. Screening is the answer.
Thank you. You have witnessed the evolution of diabetic foot care over several decades. What have you noticed changed the most?
I think that screening, certainly in many countries, is better now.
Mhm.
We started when I was editor of Diabetic Medicine, as you mentioned, back in 1990s, very early 1990s, talking about the importance of the annual review. Because if we look at all the diabetic complications, nephropathy can be silent until you present with kidney failure. Retinopathy can present with blindness, and neuropathy can present with a foot ulcer and lead to amputation. So early screening is so important. And I think the most important factor that I've really hopefully driven home is that you do not need expensive equipment to diagnose a high-risk foot in diabetes. In fact, you don't need any equipment that requires a source of power, for example. It can all be done with simple equipment wherever you are in the world.
Oh, wow, yes. So, what beliefs about diabetic foot disease did we once hold that we do know now are wrong?
I think, 50 years ago when I graduated medical school, it was felt that, okay, we can do something to slow down the inevitable amputation in people who have already got problems. And I think this was a really wrong belief that was quite common. So what I really think that people need to understand is, again, early screening. And it isn't an inevitable consequence that if you develop a foot ulcer, you're eventually going to lose your leg. And this was sort of felt, okay, we can slow down the progression. But I think we should be able to halt or even reverse the progression. And I hope that's something that's happened during my 50 years of practicing medicine.
Oh, wow. So, Dr. Bolton, what's one lesson you've learned from your patients that no medical textbook has ever taught you?
I think one lesson I've learned from patients is that they assume that if they hear from the doctor they've got neuropathy, they think, well, what is neuropathy? Okay, I don't know what it is. So I've learned from patients that really they don't understand what neuropathy is. They think it's a vascular problem. And my wife, Professor Larissa Villikite, who's an expert in that area of psychological aspects, has really done a lot of work we've done together on saying, how can we better help people with diabetes understand what neuropathy is? They don't understand, if you say, well, the nerves are dead, they don't understand that. But if you use an example, for example, of a lamp with a light and there's a wire connecting the two, if the wire breaks, the light goes out. So simple comparisons like that help people to understand. People with diabetes and neuropathy think it's a vascular problem. So they
Mm,
think, look, my can't be too bad because my feet don't hurt because they've lost pain sensation, and they're warm if they haven't got
mm,
vascular disease. And
mm,
in diabetic neuropathy, sympathetic neuropathy releases vascular tone and you get increased inflow, so you have a warm but insensitive foot. So patients think, okay, my foot is warm, it doesn't hurt because pain from childhood is important. So, for example, if you cut your finger or fall over and sprain your ankle, it's painful. If you cut the finger, you put a plaster over it and it gets better. So they think it's not painful, so it can't be serious. And if there is a problem, put a plaster on it, it'll go away. And I think these are really misconceptions, which are so important. And the lesson I've learned from patients is to help them understand what we're talking about because they don't understand, for example, what Loretta, my wife, has shown is that one of the most important symptoms of neuropathy that's not in the textbooks is people have lost balance. They're unstable,
Mm.
unsteady, and loss of balance and unsteadiness is a huge problem. And people think, well, I'm getting old. It can't be due to diabetes. It can't be due to diabetes. They don't understand that. And we can help people so much if we can explain to them in lay terms what neuropathy is, what they can do to prevent problems.
Yeah. So, like, when you said that a lot of patients lose balance secondary to the neuropathy, so also the biomechanics plays a huge role, like bracing and wearing the right shoe gear to help them walk properly.
Absolutely. But I don't think, I think we've moved a long way because when I first started, the sort of specialist footwear for people with problems with their feet were horrendous. They were cosmetically disasters, and people would not wear them.
Mm.
My head nurse was very observant, and she would look out the window, and patients walk out wearing their specialist shoes, and they're sitting on a bench outside taking them off. They say, "I can't stand the look of these things." So
Oh, yeah.
we need to provide equipment that people are going to use, and I've learned that as well a lot. And I think that the good pedorthists of footwear, specially molded, etc., today, are cosmetically attractive, and people will wear them. We have to think we're dealing here with human beings, not with people who are going to say, right, this is the treatment, and they go away with shoes that they're embarrassed to be even at home with.
I totally agree with you. Yeah, because a lot of patients, I have patients that don't want to wear it, and they don't want people asking them questions. And they don't
Exactly.
want to be labeled as a disabled person, and people start
Exactly.
saying, "What's wrong?" Yeah, so I completely agree. If every primary care physician could do one thing differently regarding neuropathy, what would you recommend that be?
I think understand that somatic neuropathy is what we're talking about. Sensory motor neuropathy is a spectrum. At one end of the disease, you've got people who have quite severe, very uncomfortable neuropathic symptoms, burning, feet are on fire, feet are freezing, altered temperature perceptions, electrical stimulation, pins and needles, etc., that keep them awake at night. And they also may have a deficit as well. That means on examination, they've got reduced sensation, reduced pain, and reduced pressure. In the middle, you've got people who have a bit of each. They've got some mild neuropathic symptoms and sensory loss. At the other end of the spectrum, you've got people with no symptoms at all. And this can be up to 50%. And 50% of these people, therefore, feel great, as I said before. No pain, feet are warm, it can't be anything wrong. So the most important thing the primary care can be doing is really to do that annual review, checking the feet, looking at them, checking the sensation, signs of autonomic dysfunction. Sympathetic neuropathy leads to dry skin, of course, callus formation due to high pressures. So looking for all these signs, clawing of the toes, reduced sensation, and these are the people that need really regular review by a podiatrist. If they are not, probably better off by looked after by a podiatrist than in primary care.
Dr. Bolton, do you believe that we focus too much on treating ulcers and not enough on preventing neuropathy?
I think, let me give you two examples. Type 2 diabetes. The average duration of disease, it's been shown in a number of studies, before people present is 8 to 12 years, say 10 years.
Oh, wow.
So people have had the condition without realizing it because they have no symptoms. It's so gradual. And, we all say, oh, well, I'm thirsty because it's hot today. And they really are not taking it seriously. I'm losing weight because, I want to lose weight. So in type 2, the symptoms may be very minimal, and therefore they can present very late, by which time neuropathy is developed. So that's the first problem. 90% of people across the US and the UK have type 2 diabetes. So many of them are going to be presenting late, sadly, and therefore preventing neuropathy it's too late. Now, we know in type 1 diabetes, there's two things. First of all, glycemic control and blood glucose control. We know from a number of big studies, good control from diagnosis, which we're much better at today with the modern technology, closed loop systems, continuous glucose monitoring, etc. And we will see a reduction in the incidence of neuropathy in type 1. But there are still people who, despite all this, end up with a dense neuropathy, and there are people whose control is terrible, who live 50 years with type 1 and don't have any signs of any complications. So it's not just glycemic control. For neuropathy, vascular factors are important: smoking, cholesterol, blood pressure, etc., but also genetics. And there must certainly be a genetic risk for neuropathy, which we haven't discovered yet.
Genetic risk. Oh, wow. Okay. Thank you for saying that. Dr. Bolton, what intervention have you noticed prevented the most amputations during your career?
What intervention has prevented, sorry?
The most the most amputations during your career.
Amputations, right.
Yeah.
I will go back to my visit to India, first visit to India in 1985 when I met Dr. Paul Brand, who everybody in diabetic neuropathy, podiatrists, physicians should know about. He was a really prominent surgeon working in leprosy in Southeast India at the CMC, Coastal Medical Center in Vellore in Tamil Nadu, near Madras. Now, tonight, I met him at a meeting, and he did so much work and was convinced that neuropathy due to leprosy was not due to the disease, but due to nerve damage. And then he became interested in diabetic foot, and he said that he told me we got to know each other well. I see the similar thing in diabetes. It's nerve damage. And he did such important work. And when in the 1980s, I think he gave a lecture in the United States, the American College of Physicians, I think it was. And he was asked, what's the most important thing we can do to reduce amputations? And of course, being in the USA, they're expecting the most up-to-date scans and expensive tests. And he said, the most important thing you can do to reduce amputations is that every time you see a patient with diabetes, take off their shoes and socks and look at the feet. And that message is so important, it's neglected, and it remains true today.
Oh, wow. Thank you. So, Dr. Bolton, do you believe? Because I know the advanced technology is not really your thing, really, but with AI emerging, do you believe it could eventually identify high risk patients before clinicians ever recognize the warning signs?
Well, interestingly, we've done was doing some studies in that area, using smart technology at least,
Mm-hmm.
and using AI to predict healing of foot ulcers, for example. I think it's going to play a major part, but I hope it never replaces the position of a good clinician who should be able to identify a diabetic foot from multiple factors that cause it by a careful examination, which perhaps one day AI will be able to do a careful clinical examination, testing all the different modalities of sensation. But I don't see it occurring in the next 10 years or so. But I'm sure it will have a place. It already has a place. For example, in diabetic eye disease, using good retinal photograph, this is more accurately defined as sensitive, very advanced retinopathy that needs treatment by using AI than it is by an ophthalmologist. So I think there will be change. It's come in diabetic retinopathy, where the screening is done by central retinal screening, and then using smart technology to say if there's a risk of advanced retinopathy that needs treatment immediately. It's going to be more difficult in the foot because it's so clinical rather than having a photograph of an eye. But I'm not up to date with all the smart technologies. Dr. Armstrong will tell you that, even though he's once my student. He would tell me that. I'm sure it will have a place.
Thank you. Of all the studies you have published, was there one in particular that surprised you the most?
Well, there's one or two, but I'll give you one example. One very early on in my days in Manchester, probably published about 1990, 1991 or something like that, which shocked me. And that was we did a population-based study of type 2 diabetes in certain regions in the northwest of England, which is where we are. And to my really great surprise and horror, it shows that older people with type 2 diabetes, 50% had significant neuropathy, that is, a loss of sensation enough to put them in a risk of foot ulcers. So that was a huge surprise to me. I never thought it was that common. So
Mm.
if you think about that, I mean, there was a good published paper from my friends in Pakistan looking at the population of Pakistan. Of course, in Indian subcontinent, diabetes is more common as it is in the Hispanic population in the US. In Pakistan, they published a paper in the last few years, and they showed the prevalence of diabetes in that country in adults was 26%. If you think about that, that means 13% of the population has diabetic neuropathy, of the whole population. That's how
Mm.
common it is, and that really brought it home. I was recently lecturing in the Middle East just before your president intervened. Fortunately, I was in Kuwait, and diabetes is exceedingly common there. And it's more common than in Pakistan. And you can imagine the huge problem in these countries. And of course, in Texas and southern United States, part of Florida, where there's a large Hispanic population, diabetic neuropathy is exceedingly common because that's the type 2 occurs in these populations more commonly. So that was one of the research studies I did. It was very simple, but had a very important message to take, and that is always screen your patients. And anybody presenting to neurology or general medicine or the ER with a foot ulcer, they haven't got diabetes. I bet many of them will have. Always screen for
Yeah. Dr. Bolton, is there an unanswered research question that keeps you up at night?
it. Well, there's many. I probably wouldn't sleep at night at all. Uh, I think perhaps prevention of neuropathy, which is very difficult to do. We've tried over the years, and it's difficult to design such a study and to get it funded. But I think the most importantly in diabetic foot ulcers is properly looking at evidence-based medicine. Some of these, it's a very simple thing, but everybody, you go to a meeting and there's all these stands for diabetic foot meetings saying, our dressing is the best, it helps cure foot ulcers. If you want to wipe the smile off the representative's face, then you ask them, where's the evidence? They say, oh, they produce a whole file of case reports. And I said, well, that's not evidence. You haven't got any evidence base at all. And they sort of burst into tears. So I think we're seeing now, for the first time in my career, well-designed and good, executed studies on new treatments for diabetic foot disease. That's what we need. There's an evidence base. We can say, look, this has been shown in a well-designed randomized controlled trial. One of these is dressing, which isn't available in the United States, the ErgoStart group, because it's classed as a drug in the United States and they have to do their studies. It's a French company. And this has been shown by nothing to do with me. I'm not sort of advertising. This was a study that was shown across Europe in a multi-country, multi-center randomized controlled trials. This was the first dressing proven to use to speed up healing in neuroischemic ulcers. This is a big step forward. We need more like that. So we can say, look, we're treating you with something that's proven in a well-designed trial. And we're going to see more of those in the next few years. I've no doubt. There are some ongoing right now.
Awesome. Awesome. So, Dr. Bolton, what area of diabetic foot research do you believe deserves more funding?
I would say every area. I'm greedy, you say greedy. But if you look at diabetic foot disease, it's common, and the mortality is worse than many forms of cancer.
Mhm.
And yet, money pours into cancer research, but it doesn't pour into diabetes research. Let me give you an example. I was lecturing in New Zealand many years ago, and I was talking about screening for diabetic foot problems. And one GP said to me, look, I can be enthused by eyes and kidneys, but I can't become interested in feet. That's a sad approach. But unfortunately, that's common. And therefore, we need to show the importance of diabetic foot disease in hospitalization, in morbidity and mortality, and in lack of good preventative medical research studies. So that's how we need to get more money. And you can frighten those who fund by the cost of the diabetic foot disease, which we will have a paper coming out soon with David Armstrong and others. We had one out with David Armstrong and others, showing the expense of diabetic foot disease, how it's so expensive to the health service, to the patient themselves, quality of life so important, etc.
Wow. So, Dr. Boulton, if you can launch one international trial tomorrow, what would you investigate in particular?
Well, I think we should be looking at new therapies for foot ulceration, not only for neuroischemic neuropathic, but neuroischemic is now the commonest foot ulcer we see in most Western countries, certainly in the US and the UK. And I think we need good studies, as I just said, in new treatments. And there are a host of new treatments coming through, but we need to fund them appropriately. And I think in the USA, the NIH has set up a diabetic foot consortium. And that, for the first time, I was an advisor of one of their committees, is doing research across numerous centers supported by the National Institutes of Health that is looking at answers for new treatments, biomarkers, etc. And this is where the funding is coming from the government. I hope it continues to come from the government and will help answer these questions that single centers cannot answer.
So, Dr. Boulton, you've been one of the biggest advocates for multidisciplinary foot teams. Why do you believe it still remains unavailable in so many places?
Right. Well, that's a good question. The MDT has been going, for about 40, 50 years. It was my friend Mike Edmonds in London who had the first big multidisciplinary clinic at King's College Hospital. And he published a paper in 1986, I think, on the success of that service. We opened ours when I moved to Manchester. So these are models. But again, there isn't like an algorithm. I don't know about the US now, but in the UK, the financial bosses, the management like to have, this is a diabetic clinic, this is a vascular clinic, this is an orthopedic clinic, this is a pediatric clinic, etc. But they can't seem to work on a model to put them together. So I think we need to help our management understand that an MDT actually works. And that's why it's important that those who have MDTs publish and show the benefits of them. My friend Jerry Raymond in Ipswich, which is in the east of England, he did a very nice study over 10 years and showed the establishment of the MDT multidisciplinary team led to a huge reduction in amputations. We can't say whether it's the education provided, the shoes, or the podiatry, or whatever, but the team approach worked. So we need to help people realize, and I've been involved. It's easy to say that in the US and the UK, but what about Sub-Saharan Africa? What about South America? Well, I've been involved in some projects in Sub-Saharan Africa, and we published a paper on that with my good friend at Bastion, Dar es Salaam, trying to help that project in that region as well. And I was involved with setting up in the 1990s the Save the Diabetic Foot Brazil program with Linda Pedrosa in Brasilia. We started with one clinic there, and there are now 50 or 60 clinics across Brazil, including in the Amazon regions in the north. So I think it just has to be spreading the word and showing the results. And our managers understand what money is. If we show that the MDT clinic can reduce expenses, a short-term investment for a long-term saving, then that can be helpful. The problem with most politicians, they don't have a long-term outlook because they're going to have to get re-elected. So they won't see a result in their time. That's what we've got up against.
Mm. Oh, wow. I didn't think about that. Dr. Bolton, which specialty do you feel is the most overlooked specialty in diabetic foot care?
I think if you look at the team, probably the least important is the physician. I'm speaking as a physician. And the most important is the patient. They have to understand what's going on, and they need to want to be helped, and we can help them to want to be helped. I think the pedorthist, and many clinics don't have a pedorthist. That's a pivotal person
Yeah.
because Good foot design is so important in the management of diabetic foot disease, particularly in prevention of recurrence. Now, most important thing is recurrence, okay? Because you can heal an ulcer, but can you prevent recurrence? The results show that the best centers of all have a recurrence rate of 30 to 50% per annum. So that's why, as David has suggested, we shouldn't be calling this, okay, your ulcer's healed, go for follow-up with a podiatrist. You say your ulcer is in remission, because there's a likely chance it will come back, and we want to prevent that. So I think that's so important. So I'd say that the pedorthist is one of the most important members in the team that some people don't have. Perhaps a diabetes specialist nurse or nurse educator, perhaps a psychologist. And of course, the podiatrist is also pivotal. The others, the surgeons, everybody's important. But I think the most important and neglected may be the pedorthist.
Thank you. So you've worked with clinicians all over the world. What countries have impressed you the most with their innovation and their approach to diabetic foot care?
Well, I've seen excellent services in Australia and New Zealand. They're absolutely excellent. They have good podiatry schools there, which are very few podiatry schools across the world. Most of those in the Middle East and Asia are trained in the US or in the UK or Scandinavia. There's a good projects have set up clinics in South Africa. Now, I think I mentioned Brazil. Canada has good services, and certainly Ireland, and also the Scandinavian countries have very good diabetic foot care. I've visited them, and more so because I was in charge of European postgraduate education for the European Diabetes Association soon after the end of the Cold War, and those are very difficult times. But many of the countries, for example, in the Baltic states and Poland and the Ukraine before this terrible business, have very good foot service, or had. I've been honored to train people from all those countries. So I think that, these are good models of what can be done, even in difficult financial and political times.
If the World Health Organization, the WHO, asked you to create a worldwide diabetic foot initiative, what would you first recommend?
Well, I'll come back to the beginning. You don't get anywhere unless you screen. And I think
Thank you.
an acceptable global screening program and the International Working Group for Diabetic Foot, based in the Netherlands, which has members from all over the world and have been very good at this, setting up guidelines as to how to do this. And I think let's have this across the world, especially in needy countries, which we forget about, sub-Saharan Africa and areas of Asia, especially in the subcontinent, South America, Central America. There are many countries suffering from poverty and disease. This is probably one of the cheapest ones to screen for and prevent.
Thank you. Do you feel that the healthcare systems are measuring the wrong outcomes when it comes to
That's a good
diabetic?
question, isn't it? Um, yeah, I think, we want to have hard outcomes. For example, a lot of people measured amputation. You think, oh, that's a very good hard outcome. If you think about it, it isn't, because if you're going to have an amputation, it depends. First of all, the patient said, I'd rather have anything but an amputation, so I'll just try without it. And another one, the surgeon, maybe someone who thinks an amputation are really pressed for it, or someone say, well, let's go ahead. And another thing is being used as an endpoint is peripheral arterial disease. But how do you measure that? So there have been many problems, and one study failed because they had amputation as an endpoint, and revascularization of the lower limb. Again, that depends on the patient. They say, oh, look, it's not too bad. I'll wait. I won't have a bypass or angioplasty. And the surgeon may be more conservative, more aggressive. And so you have to have firm outcomes. Obviously, death is a hard outcome, but obviously agreed outcomes in clinical trials, such as percentage wound healing or time to wound healing, etc. And there are now a number of papers published in the last 10 years from groups, which myself and my wife Loretta and David Armstrong, William Jeffcoat, a whole host of people have been involved in how to do a good clinical trial. And the secret of the future is, whatever you're trying, to have a trial that's agreed that it's the right endpoint. You don't forget offloading. Everybody forgets offloading. Companies will forget that a patient will walk on a foot ulcer because they don't feel pain. And one of my junior doctors said to me, "Look at that patient. They must be stupid. They're walking with a hole under their foot." So I said, "No, they're not stupid. You are. You're stupid
Oh,
because you
wow.
don't know what it is to lose the gift of pain." So that's the problem we're up against. Understanding what it is and why patients don't follow advice to wear offloading devices. Because we forget that they may be more unstable, more likely to fall because they've got lots of this sensation of proprioception. And we forget that it isn't very cosmetically attractive to wear a big boot. It draws attention. So there's many aspects like this have to be concerned in doing a clinical trial. And that's why so many trials, especially in the 1990s and the early 21st century, have failed miserably. Because I look at the instructions and the guidelines and it says offloading is very important and will be decided by each center. That's going to fail because the patient or the study patient or the subject, whatever you want to call them, will not wear it unless they realize why it's important to wear it. So it's such a difficult area to study, and that's why companies are frightened of the diabetic foot because they see the trials in diabetic nephropathy. You take a tablet, and the patient does very well. In retinopathy, you give laser treatment or whatever, and they do very well. But diabetic foot ulcers, you put them in a trial, and everything you think works in animals seems to fail. That's because of poor trial design.
Dr. Boulton, if every person living with diabetes around the world could hear one message from you today, one message that could help save a limb or even their life, what would you want them to remember?
Yeah, I'll come back to the advice of Dr. Paul Brand, that surgeon. He, as I told you, said the most important is to remove the shoes and socks and examine the feet. That's true for the people with diabetes as well. Now, I don't think that's needed for everyone. If I look at my young type 1 diabetes patients, they know they walk on beaches, they know to be taught not to wear barefoot, but you need to examine their feet annually in the primary care or secondary care as we do, just to check there's no signs of any of the complications of diabetes, particularly in the foot. If there aren't, then they can carry on as someone without diabetes till the next year. If they have got problems, that's when you need to intervene. So I think to remind those, the most important step forward would be those people who have got risk factors for foot ulcers, especially if they haven't had them, to understand why it's so important for them to check their feet each day and wear sensible shoes, etc. And we've had patient groups, and that helps people to understand because they can compare notes and say, "Oh, I'm not alone." That kind of thing helps.
Mhm. Thank you so much, Dr. Bolton. We only have like a little bit less than 10 minutes left. So the last 10 minutes is the rapid fire. So it's just first response answers for questions that you never heard from me before. So when you think limb salvage, does any of it mean anything beyond the foot to you when you think of limb salvage?
But yes, it's not only the foot; it's the leg. Limb salvage should be prevention of amputation at any level. And we've come a long way because of the multidisciplinary team and vascular surgery, especially non-invasive or partially invasive percutaneous treatments such as angioplasty, distal angioplasty. We're coming a long way, and we're doing much better, not only saving the foot, but saving the leg as well.
Wow. Dr. Bolton, what's one clinical tool you believe every healthcare professional should master?
Well, you think I'm going to say the monofilament? Uh,
Yeah.
so perhaps I won't. I won't say the monofilament because I think people have difficulty with the monofilament. How many toes to check? How many areas they're putting? It can be quite time consuming. How to use it and what to tell the patient. A tuning fork is probably just as good. A tuning fork, 128 Hertz tuning fork. And we published a study in Manchester soon after I came there using the biaesthesiometer. I'm not suggesting that you know what that is. And that is if you've got moderate to severe loss of sensation, as measured by the VPT, you've got a 7-fold increased risk of getting your first ulcer. That's that. We also showed in a study when I was in Miami that not feeling a 128 Hertz tuning fork over the hallux apex is just as good as the biathesiometer. So, you can carry a 128 hertz tuning fork with you, and you can also do a bit of piano tuning as well and make some money.
Okay. Okay. What does success look like for a diabetic foot care team 10 years from now?
I think success means having, I look at it more like a
Mhm,
family of people, and the patient is part of that family. Or I should say the person with diabetes. And they know us, and they know if they've
mhm,
got a problem, they come back quickly. So having a family together, and the most impressive thing you can do, that's the most rewarding, is if you keep careful records and you can show that in the 10 years since you've started a multidisciplinary team and having group meetings and discussing with patients, you've led to a significant reduction in recurrent foot ulcers, or not in remission, coming out of remission, in other words, and reduction in amputations at whatever level it is. Even if you've got an increase in local amputations, say a toe or a ray excision, if that's accompanied by a much more significant reduction in the larger or more major amputations below or above knee, then that's a step forward too.
yeah, I really like that, what you just said, it's a family. I
Yeah,
really like that.
we call them
That's
the foot
really nice.
family. Yeah.
The foot family. Alliteration, I love it. Okay, so why do you think the world should be watching the diabetic foot?
Well, I think they should be not necessarily watching them, but be aware of it, uh,
Mhm,
because diabetes occurs in every country in the world. Diabetic foot ulcers occur every country in the world. There's no escape, but there can be a reduction in incidence by all the features we've talked about. And I think that governments, and especially healthcare ministers, need to understand that. And they need to understand that also. And one stimulus for them is to tell them the cost of a foot ulcer, the cost of an amputation. And if we can prevent those, that's a huge saving. They go by finances, how much is spent on diabetes care. It's a huge amount, 10% of the
mhm.
whole global economy, some people suggest. So we need to reduce that, and that can only occur by early intervention, early screening.
Thank you. This is the last question. Professor Bolton, after a lifetime dedicated to diabetes and diabetic foot care, what's one thing you still find fascinating about the human body?
About, sorry, what? About,
About the human body.
oh, I think the most fascinating is the whole family of people we have with foot ulcers from all over the world that I've seen, all different colors, all different races, doesn't matter what they are, where they come from, but the problem is very similar. And to have a group of friends like around the world is amazing like that. And Paul Brand said when he retired, I never made much money, but the response I've had from many people with diabetic foot ulcers has been much more important to me than money could ever make. And that's the important way. You're trying to help people. You're not going to make a lot of money. There's not much private practice. I've never done any private practice in 50 years, but I've enjoyed my career. I've got many patients I've been in touch with for many years, and they're all grateful to my team, and I'm grateful to them because we've learned from them. You learn from people with diabetes, not from textbooks. That helps you start, but you learn from interaction with patients. I don't think AI can ever take that over, take it away from us. Never, uh, hopefully not anyway.
Mhm. Well,
No replace.
thank you so much, Dr. Bolton. Thank you so much for your decades of dedication, your groundbreaking contributions, and for your continued commitment to improving the lives of people living with diabetes around the entire world, Dr. Bolton.
Pleasure.
Thank you. And this has been LIMBWatch. I'm Dr. G, and take care of your feet because they take care of you.